All right, so lipids are a big part of cardiology, and I don't want to gloss over them, but I do one forum post type thing a semester, and so you have until, well, I'll post it and I'll give you a time frame to do it, but basically it's going to be looking into lipids and kind of a focus on a new class of drugs and reading a little bit about them. And my forum posts are really, how many bugs are in here? But they're really laid back. I give you some criteria, and you just have to write something thoughtful and then respond to one of your colleagues. And I don't really grade the content. I just go through and read the opinions, and sometimes I learn interesting things, and I hear your insights into what you found out. So just sort of interesting. But I'll post that probably sometime this week. I will, because the exam is next Wednesday, I'll do the same thing I did last time, and I'll do the lecture. It should be posted Friday. I have Friday off, so I should be able to get the recording done Friday morning and post it hopefully Friday afternoon, evening. And then I guess we'll do the same thing. I can do a review on Monday too if you guys thought that was helpful. Okay. All right. I think I have some, but I'll double check. Yeah. I'll double check and see what I have.
Are you lecturing next Monday before Thursday?
So I'll record those lectures Friday, and then next Monday we can do another review type thing. These early tests are really throwing me off. Okay, so lipids, we'll talk about this really quickly. We have a much longer lipid lecture next semester during endocrine, which is where you talk about it during ClinMed and PathoPhys a little bit more. But I wanted to bring it up now. So cholesterol is an important part of managing most cardiac things. So it's essential for any type of post-ACS. So anybody who's had a heart attack or STEMI, unstable angina, they should be on some sort of a anti-cholesterol regimen. And then most heart failure patients are going to be on it too. It's also a big component of stroke care and post-stroke care. So two different types of cholesterol. You have low-density lipoprotein, high-density lipoprotein. So these actually aren't cholesterols, but they're what we're measuring and calling cholesterol. These are just the ways cholesterol are transported in the body. So low-density lipoproteins are bad cholesterol. What these basically are responsible for doing is they take cholesterol from the liver where it's synthesized and bring it to cells in different parts of the body. So when you do a cholesterol panel and you see a high LDL, that means you have a high number of these proteins that are bringing cholesterol throughout the body and possibly stacking it up in your arteries where you don't want it to stack up. High-density lipoprotein is what's considered good cholesterol, and that's your cholesterol scavenger, which does the opposite. It kind of scavenges extra cholesterol, brings it back to the liver for, like, I don't know, consider the liver like a central processing plant in the body, because I don't really understand how it all works physiologically. Anyway, triglycerides are fat made by the body. They usually go hand in hand with people with high LDL and also with uncontrolled diabetes. It's a common I don't know if it's called a side effect of diabetes, but it's a common comorbidity that you'll see with diabetic patients. Their trigs are going to be elevated too. Those are the three major players. There's some other more complicated, and when we get into like very low density lipoproteins, and I'll go into that a little bit more during the lecture next semester, but this is really all I want to talk about right now. And LDL is really where I want to focus. So LDL has been the big target in all the recent literature. And for a long time, there are all these specific cholesterol goals. So ideally, if you got your LDL checked, if you're less than 100 optimal, and you can see kind of those there. Ultimately, LDL goals have kind of gone out the window. So what do we do now? Well, I think I have guidelines on the next slide. So let me skip through those really quickly. I'm just going to go to these ones, and we can go back in a second. So the 2013 CHEST guidelines came out and said, we really don't care if anyone has a specific goal LDL targeted. Unless your LDL is really high, like over 190, getting a level probably isn't all that beneficial. And they've done some research to show that by lowering people's LDL and targeting specific goals, you don't really get added benefit. What you do get benefit from, and what's pretty well established, is if you take a statin, you get a huge reduction in mortality. And it doesn't really matter what your level ends up being. It just matters that you're taking the drug, which is kind of interesting. So this is a bit of a shift in thought. There are still providers that probably target goals, and I don't think there's anything wrong with that per se. Again, guidelines are guidelines, and you don't have to follow them to a T, but just to know where the most recent guidelines are. So to contrast that a little bit, if we go back one slide, I should have reorganized these a little bit, but these were the old guidelines and where we would target people specifically. So if you had these different criteria, so CHD, equivalent risk factors, so I think they have some things down here. If you have male first-degree relative less than 55, female first-degree relative 65. This would be somebody who's had some sort of coronary event, like an early heart attack. You have a bunch of different parameters here: smoking, hypertension, HDL cholesterol. But anyway, the point is depending on how many risk factors you had, that would target what your goal should be. So you could say, okay, you smoke and have hypertension, but everything else looks great. So that's either 2 risk factors-ish, and now we're going to calculate your 10-year risk of having a stroke or a cardiovascular event. And there's calculators that can do that. You can look at American Heart has the calculator. It's called the Omnibus calculator. If you Google it, you should be able to find it. And I'm not going to go through it today, but I will go through it next spring when we talk a little bit about that. Talk about its relevance to stroke care and things like that. But the point is, this calculator looks at all these criteria. You type in your blood pressure, cholesterol levels, age, smoking, that type of stuff, and it calculates your likelihood of having an event in the next 10 years. So if your likelihood is less than, so for this person, let's say we got a smoker who's hypertensive, if their likelihood calculates to less than 10, that would be their goal. Greater than 10, they would have actually a pretty similar goal, basically the same thing. So a lot of this was like, well, where do you put the person? Do you target, 160? Maybe they have one risk factor, but their 10-year risk is kind of high because they're getting older. And the older you get, the higher your stroke risk goes up naturally. So anyway, there's all this confusion about this. And so Chest basically said, let's get rid of these guidelines, and they don't really make sense, and they aren't really evidence-based anyway. We can't prove that this does anything. And one of the big sticking points was this optimal goal. There were a lot of people who have had coronary vascular events who they were targeting this optimal goal of LDL below 70. It's really hard to get some people down there. So they're on these massive doses of statins, and they were getting side effects and all this stuff. So anyway, guidelines have changed, and we don't target these goals substantially anymore. And we really don't do much cholesterol checking per se if you don't want to. You don't have to. You can check their cholesterol initially, so you probably do a baseline check. And then you're going to probably figure out if your patient should or shouldn't be on a statin. As far as cholesterol medications go, statins are really the only ones we care about. There are other ones out there, and I'll talk about them briefly. But from an evidence perspective, statins are king. I'm not trying to push statins on you guys. I'm just saying it how it is. There's mountains of evidence for statins. They're probably one of the best studied drug classes we've ever had or probably will ever have. There's a lot of really positive evidence for them. I'm personally a believer. I know there's a lot of, if you like Google statins, there's like, one-off articles you'll read from some weird website where somebody says they kill you or whatever. And they certainly aren't without risk, and I don't think they should be in the water or anything, but they definitely have a lot of positive evidence for mortality benefits. So who's going to take a statin? Anyone with cardiovascular disease, angina, previous heart attack, stroke, or a related condition. Anyone, no matter what, if your LDL comes back over 190, that's where the guidelines would consider you to be high enough. Yes, they don't really care about your level anymore, but if it's that high, they think, yeah, you should probably be on a statin. Diabetic patients between the ages of 40 and 75 should be on a statin. And this is the most controversial part, which is what I bolded. Anyone with a greater than 7.5% chance of having a heart attack or stroke or developing CV disease within the next 10 years. So that's that calculator I was talking about. So I'll go through this again in the spring. But basically, if you plug a relatively healthy person into that calculator who's like 70 years old, they'll probably have a greater than 7.5% risk, just because of age. As you age, you have a high risk of stroke. Your coronary vascular event risk goes up too. There's nothing you can really do about it. It's just statistics. So that's the big question and controversy. It's like, well, what if I have these elderly patients in my practice? Am I supposed to push statins on them now, even though they're fine? Like lab-wise, they're healthy, they're active. Do you have to? No, these are guidelines. You don't have to do that. But the guidelines would actually say to do that. So that's kind of the interesting controversy. That was a big change with 2013. Yeah.
Did you call it the Omnibus calculator? We learned the Framingham calculator.
This is the upgrade. Framingham is very similar. They're slightly different. Yeah.
And you said
Omnibus, I think, is what they called it in the study. But if you go to American Heart, type in like American Heart risk calculator to Google, I think it'll pull up there. It's somewhere on American Heart. There's smartphone apps you can download for it too. But yeah, Framingham is essentially the same thing. And so again, will this cause people to unnecessarily take a statin? Maybe. That's the big debate here, and I don't think we really know for sure. If those people who are really healthy, but they still have that risk score being high, because they're older, is that should they be taking a statin? And that's an individual discussion you're going to have with your patients. This is a website. I'm not sure if it still works, but again, American Heart has it. If you have I think Hippocrates probably has a version of that as a calculator. You can download apps that calculate it for you too. But I'd stick to American Heart related things because that's where they're going to be the most correct and probably current. And again, it's basically the same thing as a Framingham. I think there's some subtle differences, but I can't remember what they are. I think the age criteria changed a little bit, and I think they added one thing, but I'm not sure what it is. It's very similar. All right, lifestyle changes. Lifestyle changes generally are going to help people with cholesterol, and certainly weight reduction, exercise, physical activity, and dietary changes can have an impact. Now, the guidelines would say that if you meet any of those criteria, like if you're diabetic and you're 40, it doesn't matter what you do. You could be diabetic and actually in great shape and do like parkour like this guy here. But at the end of the day, you still should be on a statin. They say that the evidence doesn't matter really what you do with your lifestyle. You still take your statin. So that's kind of an interesting debate too. But there are some things you can do. Generally speaking, from what I understand, and I think where the evidence is leading you, lifestyle changes tend to have a bigger effect on increasing HDL and not necessarily as much as decreasing LDL. And it depends on why your LDL is elevated. Some people have elevated LDL because of familial history. There's something called familial hypercholesterolemia, which is extremely difficult to treat with statins. It's very resistant to lifestyle changes. Sometimes people might just have higher cholesterol than the average person, and despite being really active and healthy, my aunt's this way. She's a very active person. She's a vegetarian, eats way healthier than I ever will in my entire life, and she just has high family cholesterol, and she takes a statin. It's like that's just kind of the way it is for her. She's okay with it, but it's some people, no matter what you try, you can't get that LDL down. HDL is another story. That one seems to be more pliable when it comes to exercise and diet. Okay, so our first step, if you need to lower your LDL, like if it's above 190, you would target that and try and get it below 190, or basically you're just going to start a person on a statin. And that's going to lower their LDL enough to be advantageous. I'll show you some stats on what type of lowering you're going to get. Next step, you're going to look at maybe targeting some of the other things. And usually this isn't really done. The one thing you'll see maybe commonly done is lowering triglycerides. So the thing about triglycerides is if they're really high and out of control, it's very difficult to get an accurate lab test to see what somebody's LDL is. So the way that LDL is measured is it's actually a calculation. So they look at total cholesterol, trigs, and maybe HDL, and there's some, I can't remember what it is off the top of my head, but there's a calculation that looks at those three variables and then gives you LDL off of that. So LDL isn't actually measured itself. And the reason I bring that up is because if trigs are really high, you can't calculate that accurately. It actually comes up with like a weird negative number, and of course that's not going to make any sense. So you have to get the trigs down. They're greater than 500. We have these drugs called fibrates that can lower those, and we'll come back to that in a lot of detail. And raising HDL is the other thing you could think about. Some statins mildly raise HDL, but not substantially. Niacin as a drug lowers LDL a bit, and it also can raise HDL. There's no evidence that raising HDL pharmacologically has improved mortality benefits, interestingly enough. There is evidence that shows that people with good HDL and even high HDL have lower risk overall. So it's kind of a catch-22. It's like, well, if I raise their HDL up a little bit, won't they get? Well, actually, they've shown that taking the drug maybe doesn't really help that much, but the people who naturally have the higher HDL seem to do better off. So I don't know. It's an interesting conundrum, but that's the way it is. So you don't have to. The point is, you don't have to give people therapy to raise their HDL. These next steps are pretty much fallen by the wayside over the years. Statins really are king when it comes to cholesterol. So what exactly is a statin? Giving you the quick rundown. Statins are also known as HMG-CoA reductase inhibitors, and HMG-CoA reductase is the enzyme that is the final step in hepatic formation of cholesterol. So you're inhibiting the specific enzyme, decreasing cholesterol formation. Therefore, your body doesn't need as much LDL to transport it around because it's not making as much, so your LDL drops substantially. Statins, depending on which one you start and what dose you start on, can lower LDL by up to 24 to 60%. So that's where we're talking about levels don't really matter. You get your baseline, somebody's LDL comes back at 200, start them on a statin. Well, theoretically, if you start them on a medium potency statin, you should drop it down to below 100s or maybe even mid 100s. But either way, You'll be below 190 at that point, and then your level technically doesn't matter all that much anymore. Statins don't lower triglycerides all that much. It's all over the board, but I don't think you can really count on them being all that effective for it. And they raise HDL very modestly. And by modestly, most people's HDL is like 40 to 60. So if you raise it by 10%, you're getting a whole whopping 4 to 6 increase on that, which is really negligible. However, statins have proven reductions and a lot of evidence for decreasing CHD mortality, stroke risk, and post-coronary procedures and total mortality as well. So that'd be like a repeat catheterization. So somebody had a heart attack, take their statin afterwards, it shows that those people are much less likely to go into another catheterization procedure. Adverse effects. Myopathy is the biggest one, muscle pain. A lot of people report this. It's quite common. Full-out muscle breakdown, profound muscle breakdown. Like, you guys talked about rhabdomyolysis. It's basically profuse muscle breakdown. It's sort of it's a drug-induced thing, but it can be sort of an autoimmune type thing as well. But it's a very rare statin reaction. But most people will get, like up to 10% will get some sort of transient muscle pain with statins. Really, the things to look out for would be there's no other source of the muscle pain. Somebody wasn't like exercising weird recently or working their yard. Usually it's bilateral, so if somebody has like knee pain on one side, probably not a statin. It could be, and it's not necessarily. It is a class side effect. So all statins can cause muscle pain, but you can switch people, and some people will do much better on one than the other. So that's an interesting thing with statins too. You don't rule out the whole class just because somebody gets really bad muscle pain. LFTs, so liver enzymes can increase a little bit. Transaminases can go up with statins. Most people just get a baseline, and that's it now. They've actually done some pretty big meta-analysis looking at people taking statins and liver enzymes. We found that people taking statins versus the general population have the same incidence of increased liver enzyme and liver failure. So it was a big scare kind of when statins came out initially, but it hasn't really panned out as to something that's a real side effect. And then there's a lot of drug interactions involving certain statins too. I've got a statin chart here. Oops, there it is. I don't have the brand names on here, but atorvastatin is Lipitor, rosuvastatin is Crestor, simvastatin is Zocor. Pravastatin and fluvastatin are older statins that are less potent, so you can see that their LDL reduction, relatively speaking, is quite a bit lower than atorvastatin and rosuvastatin. So Lipitor and Crestor are both considered to be high-potency statins and probably the most effective statins for getting the most bang for your buck in lowering. And I think this chart, I'm not sure where they got the evidence from. It's pretty accurate, but I've read that Crestor can get higher, like you can get up to over 60% reduction with Crestor. I think generally the consensus is that Crestor is the most potent statin on the market. And it's kind of funny, like if you look at 5 milligrams of Crestor is more potent than 80 milligrams of pravastatin. So you can be on a whopping dose of pravastatin and a tiny dose of rosuvastatin and get actually more benefit with the low dose. Probably less side effects too, or less side effect risk. We'll talk about where these might come into play again next spring and where we might. There's subtle differences between the different ones, but I don't care, you know that right now. We're going to come back to high potency statins briefly during acute coronary syndrome because there's new evidence that says that if you have a heart attack, you should be put on a high potency, high dose statin immediately. So you don't titrate your dose, you go straight to the top. So you do 80 milligrams of atorvastatin, I think at least 20 of rosuvastatin is what's recommended. So that's another kind of controversial thing people have been getting used to. It's like, well, I used to titrate the statin slowly to avoid muscle pain. Now you kind of hit them over the head with a hammer, statin style, right away. And some providers aren't totally comfortable on board with that. But it has been shown to be relatively safe for the most part. And again, we'll talk about the incidence of side effects and stuff like that more. But the thing I'd like you to remember is that atorvastatin and rosuvastatin, the statins, are the more potent ones. Those are the ones we're going to use in acute coronary syndrome. So we'll come back to that for the next set of lectures when I talk about that. And the PCSK9 inhibitors, which is like the least friendly acronym to remember ever. These are the new drugs that you might have read about in the news. They're kind of interesting. I'm not going to talk about them all that much because there's a whole discussion for them. I'm going to provide a bunch of references for you guys to read. You can, of course, do your own research if you'd like to, but there's going to be some guided questions that you can pick from if you want to do your own research and answer a question about PCSK9 inhibitors. They're basically the new drugs that are insanely expensive and controversial as far as what their place in therapy is. However, the evidence for them is looking pretty good. So, and the other agents I don't care about for this exam, so don't worry about it right now. It's just for your reference. We'll talk about them a little more detail next spring and go into where you might use them, why we don't really like them anymore, but for the most part, not important for this specific branch of the class. All right.